Dr. Vidal and I talked about a project that one of our senior residents is working on. He is interviewing patients who have come to the hospital with severe prostate or severe urologic problems and have a new diagnosis either of a cancer or kidney failure or some other, complication. To find out, okay, so how long have you been having symptoms, and why did it take you for so long to come to the hospital? So those are kind of the main issues would be around, knowledge, attitudes, practices, around, if a man has these symptoms, what does he do? Hopefully the research will help them by helping, the hospital or other public health authorities to know, okay, what messages do we need to transmit to the community to prevent these kinds of things from happening. Main stakeholders are the patients themselves, their families, the clinicians that see people here. Are these people going to OPD and they're just not being followed up? Are they afraid to go to the surgeon because they don't want someone to, see them, or they're afraid they might have to get a prostate exam? Really the highest influence we would expect would be from the patients themselves, and maybe other, one of the other questions that we have no idea about is, do people use herbalists for this kind of thing? Are they going to, Kenyaji practitioners to deal with it? So they might have a vested, those practitioners may have a vested interest in the outcome or in the research, but we won't know until we start asking questions.
So this PI is engaging patients. Who else?
Just patients.
Just patients?
Yes.
So there's only one main actor that this person is narrowing on?
Yes.
All right, thank you. It's good to know that. Yet the study is on delays to care?
Yes.
Or delays to diagnosis and things like that?
Yeah.
All right.
Well, we want to give credit as a team to Bram.
Acknowledgements have started.
And his team, they had a project. It was an adherence to guideline-directed management of heart failure by the physicians in Bungoma County. So they realized that despite having guidelines on the management of heart failure, patients still had very poor prognosis. So it piqued their interest, and the main issue they were addressing were availability of the updated guidelines and even the necessary, drugs and resources for the management of heart failure. The other issue was on the poor prognosis itself and knowledge level among the physicians or the healthcare workforce that were attending to these patients and the patients themselves. So for the impact, they aimed to reduce heart failure, poor prognosis. I believe they did that. Then they also intended to identify gaps in management within the hospital. Their stakeholders were the patients, healthcare workforce, the county government, and MOH. So, again, these were the people who influenced management of heart failure. Most from the administrative point, we had the county government and even health administrators. Yes, one of the projects.
All right, thank you so much for sharing. So the first study is about delay to care, and there could be the three model of delay easily fit here. But you notice that the actor that has been narrowed on is only the patients, all right? Do you feel that this study would have benefited from other actors being engaged in this study? And who would those actors be that come to mind when you're thinking about prostate cancer, urinalysis, you name it, other problems, who would be another key actor of interest to this kind of a PI?
The care, well, not caregivers, like the patients next of kin, or those living with them.
So significant others,
Mm-hmm.
especially for the elderly, because maybe they wait on my M-Pesa for them to go to care and things like that, isn't it? Even my advice, maybe they, like my parents are living with diabetes and hypertension, they are always calling me a Sivanemo to make decisions to go to do. So the question here, you can see this group had a lot of stakeholders already engaged and mapped, and this group has less. So it quite often has implications, and we will see how. Now, community engaged research, I really like this quote by Yunus. They say universities and funding agencies are increasingly encouraging community engaged scholarship, whereby the community is seen as a primary partner in defining and focusing the studies that we do. All right, so if a university is a repository of knowledge, then some of this knowledge should spill over to the neighboring communities. A university should not be an island where academics reach out at higher and higher levels of knowledge without sharing any of their findings. So this slide is reminding us that it's important to map when you have the question at hand. It's clear there's a problem, heart failure is a problem. You ask yourself very early, who would be a stakeholder? Forget even key, you can now start arranging them according to influence and how much they can add value to the project that you're doing. But the key thing to remember here, a place like this, Chogoria, where it's a learning center in medical issues, people look up to you, and we should be doing something about what's happening in the community, and I'm happy already to see what you're doing. How do you define community? A community shares quite often, they'll say, oh, the Meru from the Murima. So they are defining you using a geography, isn't it? Or the Maasai from Kajiado, you're using geography. But there's also the issue of, culture. Oh, the Maasai, the guys who walk around almost naked, just wearing a kanga. They're defining, by they are Maasai. These are my people. They are defining me using what we call material culture. They like cows. Maybe those are our values. Oh, they do this. Oh, they are polygamous. Those are our values around marriage. So you can use also culture to define a community. And we talk about race also, and that you may say, the people from the Caucasian group, or the black people, so here people again can use race to define a community. But the key things to remember is that, the key things coming out is that you can't be a community on your own. There has to be a group for it to be called a community. So it's a people, you must belong to more than you, and it's a group. Even what about monkeys, they also want to be, which ones are velvet? They want to go all of them together. They are a community of, anyway. So, but the key thing to remember from this slide is that actually we belong to so many communities in our lifetime. You belong to remember when I was in college, I was in the Christian Union, that was a community. Within the university, it's carved into its own, it has its own culture. We had the Muslim students, there's a way they did their thing on a certain, you see what I mean? So if, right now, think about, you're in a chama, see that one does what another chama, especially women, we're in many chamas. So many little, but the key thing is there's a common value or a common culture. There's something going on that brings you together. So when you're thinking about, and when the protocol comes, check, who do they say is your study population? Sometimes people say, I'll go to the community and collect data. Which community? When I step out of this gate, I can think of community 1,000 ways. So we need to build this capacity in our researchers to understand that when you're defining a community, it should be clear. So maybe before I go there, when you think about research, I've seen people defining now, I will do my study in the ANC. So your community of research will be the department where ANC is running, yeah? And your research participants will be those mothers coming to the ANC, it will be those nurses working in the ANC, and you may want to talk to the health administrator because of the type of research you're doing. So your research community, the first level is that it's the Chogoria facility. Are we together up to there? But when now the Iserc asks you, can you be specific about who you will be recruiting and where? Then you say, in the hospital, I will go to the ANC department, and there, I want to talk to the spouses and the mothers and also the nurses. So you can see now this person is understanding what their community of research is. And quite often this has been hazy and people miss it. So community engaged research, according to CDC, is the process of working collaboratively. Here is the key word, to address the issues of interest to the community. And that's why I keep saying, do you know the priority needs of this county, what they want to fund for health in this year? What are the priority health needs right now for research in our country? That information is supposed to be public. So that even when you're writing a grant, you can say, according to the annual plan for this county for next year, it's X, and you can justify why that is on top of the list. So it's important to understand that you can't call it community engaged if these people are just involved as data collectors or at the tail end and things like that. So we need to think about which groups of people in particular we're going to engage and in which way, and you justify the reason why they need to be involved. In the past, research has been what we call the traditional way was traditional research approach, the TRA. It's a top-down approach. I come with my research team and with our surveys, and we knock on the door, James's house, we say we are collecting data on, how we are winning the children. So you don't have to know much about it. No, I just have some questions. You consent them and you go, you collect your data, you go to a nice, which is the biggest hotel here in Togore. You go to the big hotel there and you disseminate your findings to your peers, then you write in big journals and you go to Mombasa for the KPA or whatever conference, and it's helicopter research really. Yes, you got my consent and all that, but remember what I was asking about the significance of that work. So you finish and go, and it's still okay, but we are encouraging, we're saying for community engaged ethical way of doing research, we are encouraging the green. You want that collaboration only, and you want them to be sort of your peers. Actually, they're the holders of the knowledge. Remember what we said about Spradley? I want to wear the shoe the way you wear the shoe. So you need to come, we need to come from the citadel of knowledge to the level of the patients and their caregivers and any other participant in our study, and have a dialogue about the topic of interest. And we stop calling people subjects. It's a very colonial term, I don't know. And I have given you some readings, you won't see that distress. Why fuss about it? We are fussing about it because we are in the business of public health. We want to promote health. We want to educate people on health issues. If you come to me with a top-down approach, I'll listen and then go away, and maybe if there was an allowance, I take it and go away.